Hi guys, I am doing my presentation on Crohn's disease and ulcerative colitis. My name is Margit Bilberry. I go to St. Mary of the Woods College. This is for Clinical Management 2 and U550 with Dr. Crystal White. So for learning objectives, we're going to determine what inflammatory bowel disease is and the difference between Crohn's and ulcerative colitis. We'll discuss the pathophysiological insult for both, consider risk factors, discuss clinical manifestations and diagnostic criteria, also go over guideline-based recommendations for treatment, and then I also have a case study and review questions, and then a concept map and references at the end. So with inflammatory bowel disease, this is a group of chronic heterogeneous immunologic diseases. It causes intestinal inflammation. Most common is going to be ulcerative colitis and Crohn's disease. I may refer to these as UC or CD throughout the presentation. Both of these have exacerbations and remissions. Both of these do cause a significant disruption to life. And so UC and CD are separate, but they share similar characteristics, causes, and same pharmacological agents. So the pathophysiology for ulcerative colitis. This is an inflammatory process. It is confined to the mucosa of the colon and the rectum. It is most often in the rectum and the sigmoid colon, and it's affecting the mucosa and the submucosa. So it's a little more surface than Crohn's disease, and it is further down in the GI tract. It begins with a neutrophil infiltration at the base of the crypt of the Leberkuhn. The colon's epithelial barrier becomes leaky. This allows bacteria and antigens from the gut's lumen to contact immune cells, which then produces a Th2-like immune response. This increases the cytokines, which damage the epithelium, increase permeability, and promote ongoing inflammation. This results in ulcers, erythema, friability, loss of normal structure, which leads to a crypt structure, and then you'll see crypt abscesses, which is actually a hallmark finding. This leads to ulceration, bleeding, pseudopolyps, loss of absorbent function, and this can lead to watery or bloody diarrhea. For Crohn's disease pathophysiology, this can be any part of the GI tract, so from the mouth to the rectum. It is a full thickness, so it's transmural. This is defective mucosal immunity and impaired bacterial clearance, which leads to persistent antigen stimulation. That leads to an epithelial barrier which becomes leaky and impairs mucus layer. This leads to defective Paneth cells, which is chronic stimulation, which again leads to an immune response. And this will cause transmural inflammation, which is all the layers, which leads to deep fissures, ulcers, cobblestoning, which is a hallmark find for Crohn's disease, a thickened bowel wall, fat wrapping, fistulas, and strictures, and then granulomas can also form. So in Crohn's disease, granulomas are clusters of immune cells that form in the deep lining of the intestine, attempting to wall off what the body perceives as a foreign substance. They are a key microscopic hallmark of Crohn's disease, though they don't always appear in all patients, and their presence is often associated with a more severe and aggressive Crohn's disease. You will find skip lesions or cobblestone appearance, ulcers and edema, and patches of the bowel. So here is a picture to help kind of differentiate for you. On the left, you'll see healthy, it's smooth, you can easily pass through. In the middle is ulcerative colitis, so you can see some darkening there, some ulcers and pseudopolyps. And then with Crohn's disease, you can tell that it involves much more than just that surface layer. You're going to notice the wall is thickened. You can't pass through as well. There's ulcers and then that cobblestoning hallmark sign. So it's like, I would describe it as like indentions, like it's a bumpy road to get through. Risk factors. So this is an immune response, so there's not necessarily a whole lot of risk factors. I did find family history and then some triggers, which would be antibiotic use, chronic use of NSAIDs, stress, smoking, but this is actually just with Crohn's disease, not ulcerative colitis. And then some foods that can trigger it would be alcohol, carbonated and caffeinated drinks, food with dairy, food with a lot of fiber, and greasy foods. So clinical manifestations, I went ahead and made a little graph here that shows you kind of the difference between UC and CD, and this is what patients may report to you. So with ulcerative colitis, you'll have bloody diarrhea. This is classic. But with Crohn's disease, they will have diarrhea, but it's usually not bloody. It can be, but not as prominent as UC. With UC, there's an urgency to have a bowel movement. So when these people need a bathroom, they need a bathroom quickly. Also, whenever they do have a bowel movement, they feel like there may be more to get out. They feel like it's kind of incomplete. And then there's also lower left quadrant cramping. With Crohn's disease, it's usually on the right side for pain, but cramping can be anywhere. It can be diffuse or localized. With UC, there is mucus in the stool. You don't usually see this with Crohn's disease. Another key difference between UC and CD is UC has frequent small volume stools, whereas Crohn's has large volume diarrhea. And then with ulcerative colitis, abdominal pain is usually relieved after a bowel movement, and then it's the opposite with Crohn's. That doesn't always happen. Both are going to have fatigue, but ulcerative colitis is going to be more from that blood loss, and Crohn's disease is going to be from inflammation or malabsorption. Another key difference here is with ulcerative colitis, you may have a little weight loss, but with Crohn's disease, you will have a significant amount of weight loss usually. Some other differences, ulcerative colitis, they do have more frequent bowel movements at nighttime. Symptoms stay in the colon and the rectum, and there is less perianal disease. With Crohn's disease, you may have low-grade fever, and then you're going to have like perianal pain. You may have some discharge and some ulcers at the rectum. And then again, symptoms can be anywhere in the GI tract from the mouth all the way down to the rectum. So when these patients come in, you're obviously going to want to do a physical exam. For ulcerative colitis, it's going to be lower left quad tenderness. You may see some mild distension on the abdominal exam, and then the weight may be mild to moderate loss. And then for Crohn's disease, you'll notice right lower quadrant tenderness. On the abdominal exam, you may see masses or fullness from the abscesses, and then you will see a significant amount of weight loss or signs of malnutrition. You will want to perform a rectal exam on these patients. With the rectal exam for UC, you will see, or you could see, visible blood and mucus. And then with the rectal exam for Crohn's disease, you may see perianal fistula, skin tags, or abscesses. So diagnostic testing. So a definitive diagnosis is made by correlating the symptoms with the history and physical exam, but results of the testing help differentiate from UC and CD. So with ulcerative colitis, a sigmoidoscopy is going to be your best bet. It will show continuous inflammation that starts at the rectum and continues proximally. It'll show erythema, loss of vascularity, friability, and superficial ulcerations. And then with the biopsy, there will be crypt abscesses. With Crohn's disease, it will be a full endoscopy. You'll see skip lesions, cobblestoning, deep linear ulcers, perianal disease can be seen on the exam too. And then for that biopsy, again, it's going to be transmural inflammation, and then the granulomas may be present. Every patient with ulcerative colitis requires a colonoscopy to determine the extent of the disease, but in order to avoid perforation, this is reserved for patients who have shown improvement in their treatment. Some additional testing, and this is definitely what's going to be done in primary care. You're going to want to do a CBC. This is going to show signs of anemia, especially for ulcerative colitis. And then also like the white counts, the neutrophils, all of that, since this is an immune response type of disease. You're also going to do a CRP and an ESR, which will show the inflammatory markers. You will do stool testing to rule out any bacterial infection, and this will also show fecal calprotectin, which will show intestinal inflammation. You'll do an occult blood, which will be positive in UC and then sometimes in Crohn's. You're also going to look at metabolic panel. So this may show abnormal electrolytes from the diarrhea, and there may be a decrease in albumin due to malabsorption of nutrition. You're going to want to do iron studies and B12. B12, low iron is common in both, and then low B12 suggests that it is Crohn's disease because there could be involvement with the terminal ileum. So colonoscopy with biopsy is a gold standard, but it does come with risks. There could also be imaging, so CT, ultrasound. This could evaluate the strictures, thickening, bowel thickening, fistulas, especially with Crohn's disease. So for treatment, unfortunately, there is not a cure for either of these, but symptoms and exacerbations can be managed. So guideline-based treatment recommendations for ulcerative colitis, mild forms are going to be 5-ASA or 5-aminosalicylate acid. This is an NSAID used to treat mild to moderate inflammatory bowel disease, particularly ulcerative colitis. It works locally in the colon to reduce inflammation. You can also use topical steroids instead of systemic if it's a mild version of UC. For moderate ulcerative colitis, you can use oral steroids, immunomodulators, and biologics. And then a severe form of ulcerative colitis or acute that patient may be hospitalized. They'll be on IV steroids, cyclosporines, and even possibly a surgery for a colectomy. Maintenance drugs will be, again, 5-ASA, immunomodulators, or biologics. And then I repeated what the oral 5 ASAs are. And then a couple of the names of those there. Steroids will control severe flares, but they are not for long-term use. Immunomodulators reduce inflammation by suppressing the immune system. So this is going to be something you're going to want to manage. And then biologics target proteins made by the immune system. You can also use antidiarrheals, but these are used with great caution and should not be used during acute flare-ups. Treatment for Crohn's disease. This is similar to UC as they do use anti-inflammatories, immunosuppressants, and biologics. Forgive me if I pronounce this wrong, but Janus kinase inhibitors. This reduces inflammation. This is recommended when all other treatments have failed for Crohn's disease. They may be on antibiotics. This can reduce the amount of drainage from fistulas and abscesses. Our go-to here is Cipro and Flagyl. You can use antidiarrheals, but this is used with caution. And then pain relievers, but not NSAIDs, especially if they're on the 5 ASAs. And so nothing like ibuprofen or aspirin. They may also have to be on vitamins and supplements. This depends on if their absorption has been affected and if they're malnourished, so you may have to supplement there. So after we have learned all of that, what are we going to do with these patients? We're going to refer them to GI. These are complex illnesses with periods of exacerbation and remission. This requires lifelong intervention and follow-up. Although GI is necessary, you will have to manage symptoms and side effects of the medications. They may come to you with their exacerbations. They may be able to get in quicker to you than they can over to GI. And then long-term use of steroids and immunosuppressive drugs will dictate ongoing patient follow-up. Those all come with their own set of problems too. And then routine colonoscopy for colon cancer surveillance is necessary. So you'll take care of all their preventative measures like vaccinations too. Initial workup in labs is usually done by the primary care provider. They're usually the ones that find it. Symptom management, medication adherence, and then obviously coordination with GI specialist. So here's my case study. A 30-year-old female comes into the office for an acute visit. She states that her bowel movements have been turning into diarrhea more frequently, and she has even started to notice some blood in her stool. She states that her mother suffers from IBD. She complains of cramping on the left side of her belly that is relieved when she has a bowel movement. She reports that the urge to have a bowel movement comes very quickly, and she must find a bathroom as soon as possible. During the physical exam, you notice tenderness on the left side and just some mild distension of her belly. So based off of the information that is given so far, are you leaning more towards ulcerative colitis or Crohn's disease? So due to clinical judgment, you decide to perform a rectal exam and find that there are no skin tags, fistulas, or abscesses, but you do notice a little bit of blood. What testing are you going to suggest to the patient, and what additional labs would you order? And then after confirmed UC diagnosis and a referral to GI, how are some ways from a primary care standpoint you will continue to manage care with the patient? And then next you will find my concept map on Crohn's disease and ulcerative colitis, and then my references. Thank you.